Great. So, hi, Joel. This is Rohit Mahajan. I'm the managing partner and CEO at Big Rio and Demo Consulting. And welcome to this podcast, which is called The Big Unlock. It has been started by Paddy Padmanabhan, the previous business owner of Demo Consulting. And I'm building on his legacy. And I think we are up to 150 at this point in time in that vicinity, and it is very well regarded in the industry, and I really thank you for being able to join us today. So, would you like to start with some introductions, Joel, here and talk about a little bit about your journey so far?
Sure. Thanks very much for having me, Rohit. I'm Joel Klein. I'm the Chief Information Officer at the University of Maryland Medical System. So that's a 14 hospital system here in Maryland. We are one of the largest nonprofit employers in Maryland. I think we might actually be the largest, and one of the dominant health systems here in the DMV area. We have an academic health system in downtown Baltimore, which provides everything from multi-organ transplants to the highest acuity trauma care, bone marrow transplant, all the quaternary care, kinds of things that I think everybody's familiar with. And then we have lots of community hospitals, and we have lots of rural healthcare and ambulatory sites all across the state. So it's an integrated delivery system that operates in close partnership with the University of Maryland School of Medicine, School of Pharmacy, School of Nursing, et cetera. We're a private company that was established a number of decades ago. So we're not actually part of the university system formally, despite our name, but we operate in very close partnership with the school, and we very much are an academic health system with community components as well.
That's awesome. And Joel, I do understand that you studied to be a physician, right? I do not know if you actually practiced medicine for a while and then got into this role. So it would be very interesting to know. I'm actually very curious to know that how did you move from being a physician and perhaps practicing physician to this, side of the things?
Yeah, sure. So I am an emergency doctor.
Yeah.
I went to medical school back home in Texas at the University of Texas Southwestern Medical School, and then I did my emergency medicine training at Johns Hopkins, and was hired out of residency at one of our community hospitals in the system where I still work. And I was the night guy for many years,
Yeah.
working the night shift and taking care of everybody.
Yeah.
It was very, very busy place. At the time, it was one of the biggest emergency departments on the East Coast. We saw
Mhm.
over 100,000 visits a year, which is ginormous by ER standards.
Mhm.
It was surrounded by nursing homes and assisted living facilities, so lots of elderly patients with sepsis and hip fractures and bread and butter kind of community emergency medicine. I was elected to run my group, so it was 60 doctors and nurse practitioners and PAs. And as part of that role, I was responsible for overseeing incentive compensation because about a good chunk of how my partners and I were paid has to do with performance. And to do a good job around metrics, it meant I needed data because at the time, this is 20 years ago, that didn't really exist. It was sort of eyeballed on how good a job
Yeah.
you were doing.
Yeah.
And so that meant I had to befriend a bunch of people in IT to try to get data on things like, door to doctor time, which is a really important metric in emergency medicine, throughput
Mhm.
time, admission rates,
Mhm.
compliance with, are you giving the right antibiotics for pneumonia or sepsis or what have you, and being objective about how we were going to compensate people. So that meant data access and really starting to partner more with IT. So that's how I got into it. We started on a digital transformation journey back in 2012 in getting
Wow.
our entire organization on a single electronic medical record platform so that we all had the same situational awareness of our patients and could all operate, across the continuum of our organization on a single, platform and entity. So I was a leader very early on in that project as well.
Yeah.
And I'd say it was around 2015 that I joined the IT leadership team formally, and I became the CIO in 2019. So this is my 6th year in that role.
Oh,
I
wow. Okay. That's great. Yeah, you
Yeah,
say, yeah.
so I do still have my license. I just renewed it actually, and I am on the staff, the medical staff still at that community hospital. And I worked shifts during the first half of COVID. I would split shifts with my old partners and work, from 5A to like 9A in the morning.
Awesome. Yeah.
But the problem is I have kids and
Yeah.
a family and other things that I like to do. Plus,
Sure.
being a CIO is a little, crazy. So that
Of
got a
course.
little overwhelming. So I worked the first half of COVID,
Right.
and realized this needs to stop.
Of
So
course.
I stopped practicing about three plus years ago,
Okay.
and I could still do it if I needed
Yeah.
to, but
That's
I
wonderful to know. That's wonderful to know, Joel. So, Joel, I'm very, very impressed by your early decision in 2012 to, go for the single medical record and also start your digital transformation journey. So, it's been more than 10 years. So, perhaps I think out of these 10 plus years of experience, and especially being almost 5 plus years now in the CIO role as well, what could you share with the audience that could be some lessons learned or some roadblocks that you had to surmount, or some difficulties that you found on the way of this entire digital transformation journey? And where do you think you are at? Do you think it's completed? There's a lot more to do.
yeah.
Would like to talk about that for a few minutes. Yes.
So I mean, there's a whole bunch to talk about here, obviously, but I think if I were to pick out one key thread, You know, the thing that we're really trying to do in medicine is reduce unnecessary variation in how we care for patients. So
Mhm.
there is a best way, for instance, to manage things like pneumonia or sepsis or hip fractures or prenatal screening or how a delivery in
Mhm.
in obstetrics. There are best practices in all of these areas. And one of the biggest tools that any healthcare organization has to drive consistency and encourage all members of the care team, doctors, nurses, therapists, of all stripes to practice consistently is by having everyone on the same platform with a common set of tools and visibility into patients so that we can get data to, speak to that variation. If you're all on different platforms, if you're all, the eastern half of the country uses this and the northern half of the country uses this, you're always going to be fighting that. So you've got to get everyone on the same playing field, not just, so that you have that common situational awareness of a given patient or a given part of your organization, but it really is the way that you can get to consistency. There's so many tools in electronic medical record systems
Yeah.
that can help drive that. And I think if we don't do that and we continue to permit unwanted, unnecessary variation, then we're never going to get cost under control and we're never going to have best practices done everywhere the way they should be. So we are, we've gotten that common platform and we are, very far down the road in terms of driving towards consistency. But, that's a never ending journey. And
Yeah.
it's still, something that we are definitely working on as a system.
That's great to know. So that is very interesting that you mentioned about reducing variation and driving consistency. How would that come into play, Joel, if there was any situation of, let's say, acquisitions, where you now have to deal with, a hospital system that came into the same portfolio, or a new set of physicians, and they are not used to the same platforms or the tools or the systems that you are driving?
Yeah. A lot of health systems are dealing with this right now. I mean, this is
Yeah.
true for any acquisition, any M&A activity. So I think you could, generally speaking, divide it up into two categories. One is an acquired entity or an entity that joins, a health system or, a larger company that is smaller and less sophisticated and less mature. And in that case, usually they welcome the help.
Yeah.
Part of that's the whole rationale for why, we joined up in the first place. I know some of the organizations that joined our health system, it's change, and change is always hard. But the opportunity to benefit from all the hard work we've done over the last, 12 plus years in the
Mhm.
journey that I just described, they get to benefit from that without having to put in all that sweat equity
Right.
that we've developed. So that's one scenario. The other scenario is harder, and that's when you have two kind of like-sized organizations that
Mhm.
join forces to try to get
Mhm.
some economies of scale. And the question is, how are you going to navigate, the digital side of that merger? And it's hard.
Mhm.
Typically speaking, you've got to pick, right? You've got to say,
Yeah.
well, let's go with this one and let's extend that umbrella out.
Right.
And the challenge is having governance to say, well, how do you do it? How do we do it? And I think the hardest part is, getting that pattern, getting into a groove of compromise. And, it starts with trust. It starts with dialogue. It starts with the leaders, not just the IT leaders, but the clinical leaders and the operational
Right.
leaders,
Yeah.
having relationships with each other, and realizing that, it doesn't really matter necessarily whether we do it, whether the wallpaper is this wallpaper or that wallpaper, because they're
Mhm.
both okay. Let's
Yeah.
pick some wallpaper.
Yeah.
And that way, we don't have to spend a bunch of energy maintaining both kinds of wallpaper.
Yeah.
And, that's some of the hardest work there is. And but it's part of what makes the job fun and exciting.
That's very cool. So talking about fun and exciting, I would like to shift gears a little bit, Joel, about how do you approach innovation? What's your thought process? And in a large system, innovation is, usually difficult to do. How do you kind of gather the innovative ideas that might be coming from patients or, your nursing staff or your physicians or any other constituent or any other stakeholders in the organization?
Yeah.
So, yeah.
Right. So I think you have to think about it two ways. One is you have to, right? Everyone knows that. You have to water the plants or they won't grow. So you've got to have a way of listening for
Mhm.
innovative ideas and collecting them, and then finding a way to put some gasoline behind them and getting them the resources they need to try to
Mhm.
run with them.
Mhm.
Sometimes that involves identifying people who are out in the organization that, in my case, are not part of IT,
Mhm.
and bringing them into IT and getting them connected to larger teams that can help them. Clinical engineering is a great example in healthcare organizations where you've got people who are out there, repairing things, dealing with biomedical devices. They're not always part of IT, and how
Yeah.
you find talent in that organization that needs, some of the resources that typically IT can provide, whether that's project management or infrastructure that isn't, intrinsic to CE. That's just one example. So you've got to be listening, and you've got to find a way to run with it. On the other hand, we call it the good idea fairy, right? So when the good idea fairy shows up, and each hospital has 2 to 3 projects or pilots that they want to run with, all of a sudden you have 50 new projects,
Yeah, exactly. It
literally.
adds up quickly.
You
Yeah.
you
Yeah.
can't do that. And
Yeah.
so you've got to have some governance. Some of that governance has to be, um, you're going to need a little command and control over it as well.
Mhm.
And you've got to have people that have the right eye for success.
Mhm.
So if you have a big committee vote on things, then you're going to get into groupthink, and you'll sometimes pass real opportunities by. So you need to have people who are decision making around this stuff, who can kind of smell something good when they see it, and then have a situation where it's not a dictatorship or some backroom deal. So
Yes.
it's a really tricky balance, but you've got to
Yeah.
balance all of those things for innovation to be successful.
Right. So any examples that you could share with us or anything that pops into your mind of something that you have done, Joel, with you and your team, which is innovative and which you are thinking of like taking further along.
Yep. So, there's a ton of examples, some of which, we're really excited in terms of products that we've developed that we feel, have a serious future on the marketplace.
Yes.
But speaking generally, and running with the theme of clinical engineering, We believe that just like, all of us run around with our phones and
Mhm.
use them for so much of our daily tasks, we've
Mhm.
been spending a lot of time in our organization thinking about the devices that are in our nurses' pockets and
Mhm.
how do we get more and more of the technology that patients depend on. So everything from clinical monitors, cardiac monitors, fetal monitors, all of that
Mhm.
stuff, ventilators, patient, nurse call,
Mhm.
telemedicine, and then of course the electronic medical record system. How do we
Mhm.
put all of that on a clinical device? That is to say, that is indestructible,
Mhm.
is vomit proof,
Mhm.
because it's healthcare,
Mhm.
and in a form factor that our nurses really, love using. Because
Mhm.
a lot of the devices that we have to choose from, like an iPhone, that's a consumer device, right?
Yes,
It's not designed for this.
you're right.
And either from a form factor point of view
Yeah.
or, a user infrastructure point of view, that's not, iPhones are not built to be shared devices. They're built to be used by individual users. And
Right.
that's not really what we're going for. So you've got to wrap all of that together. That's a lot of engineering. And it has to be unifying a ton of vendors, right? What I just described, that's not one vendor, right? And so you've got to have a team that's capable of putting that engineering together from so many different platforms. And so that's an area where we are really working,
Yes.
again, to try to have something that our nurses love to use.
Right. Right, Joel. So, Joel, you mentioned something very interesting, and that ties into also, the environment which many of us are facing right now, where you have to do, more with less, like, in terms of budgets and stuff. And you said throwing gas on the kind of almost gasoline, throwing it, and you do need gasoline. You need money to kind of and resources and time and energy to kind of pursue any of these projects. So how do you do that, like with in this environment where budgets may not be available? How do you come up with money or stuff to kind of get this over the finish line?
Yeah. So
Yeah.
there's a bunch of tactics.
Yeah.
One, you have to look inside. So in
Hmm.
any IT shop, there's probably
Hmm.
stuff you're doing that you probably don't need to be doing.
Hmm. Yeah.
You have to be really, really thoughtful about that. I'm not saying, stop keeping the lights on. I'm not saying that at all.
Yeah.
But you've really got to be thoughtful about, are we doing things that are actually adding value? And you've got to be thoughtful about that. There's always folks that will try to hide with that work because
Hmm.
it's easy. And so you've just got to pay
Yeah.
a lot of attention to that. Second thing is, you've got to make it clear to your organization the value of what you're doing. You've got to talk about what you're doing and
Yeah.
talk about what's possible because, we assume the budget is X. And in my organization, the narrative from our finance community is we need to find a way of getting IT more resources. I mean, yes, there is also this narrative of, more with less and all that.
Hmm.
But I think, and remember, from a capital point of view, we've got to build new hospitals, we've got to buy new medical equipment.
Yeah.
It's a very capital intense industry. And so how you frame all of that comes back to, do they know what you're working on? So you've got to be able not just to tell the story, but to, demonstrate the art of the possible. And some of that involves making sure that everyday users know and feel the impact of what you're doing. And then, I think the last thing is good governance. So you can just, pull stuff out and say, we're not going to do this anymore. But I think a
Hmm.
much better choice is to give the organization options. So, you say, okay, we want to pull X million dollars, in cost out of the organization. Here's 5 ways to do that.
Yeah.
They're all terrible. What do you think
Right.
is the least terrible? And you have the right people around the table doing that rather
Oh,
than me making some unilateral decision. I could do it.
yeah.
As a doctor, it might be more credible, but it's
Right.
better if I do it, standing in lockstep with my peers.
Of course, of course. And since we're talking technology, Joel, there has been such a rapid change in the new technologies like Gen AI and large language models coming our way. It has kind of changed the AI landscape that we were aware of, compared to previously. Everyone has a chance to experiment with Gen AI right now. Everyone's using it in some form or the other, you like it or not. And especially, you talked about having kids. My kids are growing up with it, they're already using it to write plays and do their stuff at school. So what are some of your thoughts around AI and Gen AI and the initiatives using these sorts of technologies to accelerate the pace of innovation or for better patient care and better healthcare delivery?
Yeah, so it's obviously huge. And I won't belabor the obvious point, which is you've got to
Mhm.
think about cybersecurity, you've got to think about privacy.
Mhm.
You can't dump a bunch of protected health information into some Gen AI thing and,
Yeah.
risk that data, becomes public and leaked out with, a malformed or malicious prompt, et cetera. So that's a whole issue that we've got to come to terms with as an industry, and our vendors need to understand they're going to have to help us if we want to really lean into this stuff. So with all of that said, there's a ton that I think the industry is looking at, and we certainly are too. Ambient technology is a huge piece of this. We are piloting a number of solutions there, and it's promising, just like so many new technologies are. But I think the trick is, it is every doctor going to
Mhm.
appreciate, ambient documentation in the same way. So this is where you have a microphone in the room, typically on the doctor's phone, that records the dialogue between the doctor and the patient. And the output of that is the documentation of the visit, which can take, 5-10 minutes per patient if I'm doing it sitting at a keyboard, and all of maybe 60 seconds to review if I'm just looking over what the AI did.
Mhm.
So that's promising. But again, you've got, maybe a third to half of providers that love it.
Mhm.
You've got, a chunk that say, nah. And then you've
Mhm.
got a chunk who, what do they think? So how do we think about those different providers? How do they adopt it? How can we coach people to adopt things? It's like autopilots in airplanes. There's going to be people who say, back in my day, we didn't have that.
Yeah.
But it's a tool for safe and efficient flight. And how do we get people there? So that's one example. Um, I think the other big thing I would point to is idea generation.
Mhm.
So, whether we're thinking about an individual patient or
Mhm.
thinking about hospital-wide strategies like patient flow, how can
Mhm.
we use AI to come up with, here's a problem, here's a patient, what are we not thinking about, in that area? That's what AI is so, good at
Mhm.
for it's thinking about things differently.
Yes.
Um, so those are some of the thoughts that, that we're thinking about.
That's pretty good. That's pretty good. So you're already looking at possibly using Gen AI in it's crossing functional areas now. So you can actually use it in many different functional areas at the hospital system.
Right.
So I guess you're looking into that. You mentioned to me early on before we started the podcast, Joel, about that you were at a VC conference and that you might want to share some thoughts and ideas from your visit at that conference. So, what are some of the thoughts there?
Yes, well, so I guess I'd say two things. It was an amazing meeting. There was about 250 or so CIOs from all different industries, including some of the biggest companies in the country. Um, I think what's fascinating is how all of us in IT leadership are fighting the same battles,
Yeah.
right? We're all dealing with vendors that are, engaging in really punitive price increases.
Hmm.
That they'll acquire something and then jack the price 500%. It's not
Hmm.
going to work.
Hmm.
We will find a way out of that. It's a huge problem.
Hmm.
Um, we're all dealing with AI. We're all dealing, with productivity vendors. We're all dealing with, capital challenges. The
Hmm.
vendors, whether that's an ERP vendor or,
Hmm.
CRM or any of it, we're all doing the same stuff, no matter what the industry is. It's just fascinating to hear that. I think
Hmm.
the other idea that I heard
Hmm.
was using AI for idea generation.
Hmm.
So, where the prompt is, here's a business problem that we have.
Hmm.
Give me 5 unorthodox solutions that I didn't think about. Or, really crazy prompts. Like imagine, the following business problem. How would, the Middle Ages have dealt with this? How would this have been handled in feudal times? And it sounds like a ridiculous idea,
Yeah,
right?
sure. Yeah,
But it's not, because if
yeah,
it gives you a spark,
yeah,
like some little way of connecting it. And what I heard from a lot of my colleagues at big companies is that's what they're doing to
yeah,
try to get an edge on their competitors. And I love it because that just sounds wild and fun.
of course.
It's a great way to keep, us all collectively engaged at
Sure.
the highest levels with solving some of the toughest problems that we've got today.
Right. So one big wave coming at our way, and I'm shifting gears away from technology for a moment here, but would love to get your thoughts on it, Joel, is about value-based care, right? So are you already in the midst of that? Are you planning for that? And what are some of your, suggestions and advice for people who are thinking about that?
Yeah, so value-based care is not new. This is, something
Oh,
that I think the whole industry has been trying to figure out,
yeah,
in some cases very successfully, and in some cases not so successfully. And it's this whole idea of, do you have skin in the game, for some block of covered lives. Um, I think it comes back to, how much can we focus on primary prevention? And, as long as we have contracts for, this is Joel's opinion, as long as we're talking in terms of single year, time periods of responsibility, primary care is always going to take a back seat. So, in other words,
yeah,
if I'm really accountable for getting patients to lose 20 pounds because of the health upside of that from a heart disease, hip replacement, there's just so many ways, right?
sure.
But if that's only, if I'm only responsible for, between now and the end of the fiscal year, I'm not going to worry too much
Yeah,
about that,
it's too
right?
short a time period.
It's
Yeah,
too short a time period.
yeah,
And so, how do we think about that? To me, that's something that the whole VBC, space needs to think more about. And then, how can we partner better with payers, who are the intermediaries here? There's a lot of people who say, the payers just suck money out of the system and they're just bureaucracy and they're, skimming 10, 15%. And I think it's more complicated and nuanced than that. They do have the ability to help providers, the provider side, be more strategic about how they apply resources. I think
yeah.
it's, more than just, we'll give you some analytics, we'll give you a list of things to do, but I think there's opportunity there.
That's great. That's great. So, Joel, with that, would you like to share some final thoughts on, any new initiatives around digital transformation that you're thinking of in the next, let's say, few months, few years? Or generally speaking, if you looked in the crystal ball, what do you see coming your way or our way as industry? Yeah.
Yeah. You know, Part of why I love my job is the whiplash.
Yeah.
So I'm going from this conversation to a meeting about how we can support philanthropy more
Mhm.
aggressively. And then my meeting after that is with our CTO to talk about all the projects we have going on there. And then my afternoon is focused on our informatics team and how I mean, that's like typical. And so,
Yeah.
it's great because there's so much to do in our industry. I don't think I'm alone. And to sort of point to any one thing would be, saying, "Well, I love this child best." There's just so much, and to
That's
me,
awesome.
that's what's so much fun about this job.
That's awesome. Yeah, and especially everything is driving to better patient care. So that's an awesome direction to go into. Thank you, Joel. Really appreciate you being on the podcast. I will close the recording now, and then we can chat for a few more minutes.
Sure.
Thank you.